42-year-old female who's diagnosed with a thyroid disorder. Which of the following explains the body's primary self-regulating mechanism to maintain hormone homeostasis? It's not technically a thyroid question. I'm leaning on intro to endocrinology. Maybe it's D. Anybody for A or D? Anybody for D? No.
I have no idea.
Don't. Yeah. Okay, good job.
Put that up.
Again, this is like the verbiage of a negative feedback loop. I like the pictures way better. But again, if there's high levels of circulating hormone, endocrine system responds by decreasing synthesis and secretion of the hormones ahead of it. Okay. All right. Which of the following describes an endocrine hypofunction within the pituitary? Primary, secondary, resistance, or ectopic? Yeah, secondary, right? If it was primary, it'd be in the actual gland itself, the thyroid gland, the adrenals. Oh, it's really great back here. Okay, it's resistance. Resistance is hypofunction, right? That's like what we learned about with ADH, where the kidneys were resistant to ADH. What's an example of ectopic? Something out like a tumor, right? And usually we're going to see that hyperfunction. So that's why it's secondary. Why it's not the other ones. All right, getting a little bit tougher. We're in lesson 2, and we're talking about labs. So we have a 34-year-old male who presents with signs and symptoms consistent with SIADH. Inappropriate ADH. Which of the following lab values would be used? Feel free to yell out a letter, A through E, A. You want to Bravo, Charlie? We'll go through it together. So the answer is E. Well, why? Okay, so SIADH is ADH high or low? High, right? It's inappropriate release. The body did not trigger this, right? It wasn't osmolality that triggers it. So if I have high ADH, what happens to my my sodium? Diluted. So we can already go down to Bravo or Echo, right? Or so we have B or E, hyponatremia. So we can go to that. And then what happens to my kidney, my urine? It gets concentrated, and so my specific gravity would be high. So you can see how you would, why it's not the other ones, and how you would differentiate it. And all you really have to know is think back to ADH itself and physiologically what happens when ADH is next. Okay? Versus memorizing the table of when SIADH, this is low, this is high. Go back to physiology too. Okay? Here's your labs, all the corresponding labs, and why that answer is correct. All right, so next question, we have a 41-year-old male presents with polyuria, and polydipsia for 2 to 3 months. He's alert and oriented, no acute distress, so he's conscious. He has a normal physical exam. Which of the following lab values would you expect for this patient? What's the diagnosis? DI, right? We're not sure which one, but DI. He's conscious. Is ADH high or low in this patient? Low, right? Opposite of SIADH, we forgot. So, what? A, B, C, or D, or E? I hear C, I hear an A.
B.
C and A, C and A. Okay. All right. So, C, let's talk about why. So, ADH, let's look at the urine first. What do we expect? High urine specific gravity or low urine specific gravity? Low, because we have excess diluted water, right? Polyuria, it's in the name. And polydipsia, he's conscious, he's drinking water. All right, so we've got to narrow down to 3. This is why this question is really hard, and why I have it on practice, not necessarily the exam. So why is it normal natremia versus hypo? He's replacing it, right? He's compensating. He's fixing it himself. So odds are it's normal. It could be hyper too, potentially, especially if his thirst center isn't working or he's unconscious or dehydrated. That is why it is C. So again, The urine stuff makes sense. And this is that, why this sodium is likely normal. Could be high, but likely normal. All right. So we're moving on, changing gears away from the posterior pituitary today. And pretty much the rest of the block is all anterior. All right. What we're going to go over, we're going to talk about a lot more conditions today. A lot more conditions. But we won't go, especially down here in the anterior hypopituitary, we don't go into as much detail as these. Okay, so hypothalamic pituitary axis. So it's the communication between the hypothalamus and the pituitary gland. The hypothalamus is essentially like the control center. The pituitary is a really, really important piece of that. And when your hormones are low in the body, it communicates that negative feedback up to the hypothalamus as well as the anterior pituitary. So I focus a lot more on anterior pituitary in this class. Just understand there's a relationship between the two and how they work together. So HPA is that hypothalamic pituitary axis. Like we learned yesterday, that the pituitary is nice and small, and the cella turcica. Anterior pituitary makes up 80% of the function. And how crazy is this? It's so small. So something so tiny tucked away in here deals with so much of the body, and when it's either hypo or hyper, it causes a lot of problems. Body's pretty cool. So this is a true gland. So again, you have your hypothalamus up here. Hormones are released, inhibitory or releasing hormones are released from the hypothalamus through the bloodstream to the anterior pituitary, and that's where your hormones are synthesized and released through the bloodstream to the target organ. From growth, development, mood, metabolic, sexual development, lots of things are controlled through this gland. Like fun FYI things about the pituitary, it doubles in size. Fun facts, I guess, about the pituitary, it doubles in size during pregnancy, and then as we get older, it shrinks. So, what's your guess? If you had to guess when you have a patient with thyroid disease and they're pregnant, do they need more thyroid when they're pregnant or less? Probably more, right? If it doubles in size during pregnancy, you need more hormones, right? Because you're not just dealing with mom, you're dealing with mom plus baby. And then as we get older, maybe our lab ranges for thyroid disease and other things change, right? Because as we get older, maybe we don't need as high of levels as we did. Because again, pituitary gland shrinks. So you can tie these fun facts to stuff later on. We looked at this yesterday. We know all things ADH now. We'll remember those forever. And then this is what we're going to talk about, all things. There's a lot more hormones today, the next day, the day after that. So, this is a lot. A lot, right? So this, by the end of this, you're going to know this. You're going to know this. You can come back to this slide and be like, oh, okay, I got it. But look, we've already learned this little side over here. We're going to talk about all of this.
We talked about it.
So, the hypothalamus, it releases two types of hormones, stimulating and inhibiting. Luckily, the names tell you exactly what it's going to do, right? Prolactin, releasing hormone. Thyrotropin, releasing hormone. What's that? What is thyrotropin? Like thyroid, right? Growth hormone, releasing hormone. Growth hormone, right? And then we have it on the opposite side, there's inhibiting. So we have growth hormone inhibiting hormone, which is called somatostatin. For the prolactin inhibiting hormone, it's dopamine. Okay, so you don't have to memorize this list, but it does come up a few times throughout the lecture. These you will know. You won't be able to forget these. We're going to talk about each one in detail. I like this slide a lot because, again, it shows the hypothalamic inhibiting and releasing hormones at the top in the purple. And then it goes to the pituitary in the, I guess, the orange. And tells me the target organ. Okay. Yeah, just like with everything in medicine, there's exceptions to the rules, right? And here, there's more than just this, but the top three are ones that we're going to talk about. I need you to understand. but I'm introducing to you 4 kind of exceptions, and they're called common cross-reacting hormones. So, thyrotropin-releasing hormone, so TRH, which stimulates the release of TSH, right? Also can stimulate prolactin. So when we have someone with hypothyroidism, what does that hypothyroidism means? What? We have not enough thyroid hormone in the body. So the hypothalamus is going to increase TRH and then therefore TSH. In that process, it can also stimulate excess prolactin. So we'll talk about what that means here soon. ACTH stimulates melanocyte stimulating hormone, or alpha MSH. So that's why people with Addison's have darkening of their skin. Okay, it's that excess ACTH causes an increase in MSH, and then they get the hyperpigmentation. Okay. Prolactin can inhibit LH. That is really useful in the signs and symptoms of somebody with excess prolactin, and it'll all come together here soon. Okay. And then the last thing is more just like an overall concept, is anytime you have someone with a growth hormone issue, you just need to check their thyroid too. They typically overlap. That's all that means. And here, the slide I liked, I still like it, right? It points to how TRH, not only does it stimulate TSH, it can mess with prolactin. Prolactin can inhibit LH and then the ACTH. It's kind of messy, but all right. Any questions about hormones and an introduction to all things anterior pituitary? All right. So the next, 50 some odd slides, we're going to be talking about adenomas. So remember our terminology from yesterday. Adenoma is a group of glandular cells that can secrete hormones. Not all of them do, right? But these are benign tumors. They account for 10 to 15% of brain tumors. They can be found incidentally, especially if they're small and they're non-secretory. And again, found in 16% of brain MRIs. The non-functioning, you're more likely to be a male with those, and they increase incidence with age. I don't expect you to memorize the percentages and all of that stuff, but it just kind of sets the stage moving forward. But again, most are small. The size for a microadenoma is less than 1 centimeter. Again, that's primarily you're going to see microadenomas. And then macroadenomas are over 1 centimeter, and they tend to be more aggressive. Yes, they tend to be more seen in males, but more aggressive than functioning. Why? Why is a macroadenoma going to be more bothersome? Yeah, it's bigger, right? There's no space for this big adenoma. Pituitary only has so much space, and then you have this big thing, it's going to be more aggravating and cause some space-occupying effects. And then the difference, obviously, functioning is equivalent to does it secrete hormones? So it either secretes one or more, or none at all. This is some more terminology, classification slide. So there's 5 types of pituitary adenomas. We're going to dive into the top 4, spending the most time on the top 3. You can see the 2 that I'm leaving out tells you exactly what the problem is, right? TSH secreting adenomas, super, super rare, but an adenoma secreting too much TSH, and then gonadotropin. Okay. They're really rare. They kind of follow the same principle. So when what kind of imaging should I do for somebody who I think has a pituitary adenoma? Look at the brain, right? CT or MRI? MRI, yeah. So it can be MRI. CT you can do. Like CTs are really helpful, which you'll learn in neuro. You probably learn in RADs, but look at the right on the MRI. It's much clearer. Because how big is that pituitary? It's really little. And a microadenoma is less than 1 centimeter. I want the best picture I can. So we're going to do a MRI is our imaging of choice. And can anybody see the microadenoma on the top? I could. But it's there. You'll see in a second. What about the second page?
Oh, that's a big one.
Yeah, this is what looks a little different. And what about the, oh my goodness, adenoma? Yeah. Yeah. That's real big. So again, MRIs all for those macroadenomas, just kind of just explain, so there's only so much space. And if it gets bigger, you get these space-occupying symptoms. You're going to have cranial nerve palsies. You can have compression of the optic chiasm and headaches. What do you think? So the pituitary gland sits right there on the optic chiasm. Who remembers what visual changes your patient will have? Yeah, I wouldn't remember this, but you'll learn it again in neuro, and then you guys will be able to tell me. But it's your bitemporal hemianopsia. So they basically lose peripheral vision. So that's what you're going to have to know. And then there's a pretty picture of your pituitary tumor compressing the optic chiasm and causing what? Peripheral. Yeah.
Ma'am, is this person dead or alive?
We're going to go ahead. I don't know.
I don't even know if that's how you do the procedure.
Yeah. So not the procedure I teach you is not this. But I'd like to say, I'm assuming, but there's a lot of blood, right? So cadavers look differently. I don't know. That's a good question.
Yeah.
What makes you feel better? My brain is. I think he's probably not alive.
Then you're gonna think the same about that.
So we know we're going to do MRIs. We know they can be secrete hormones or not. We know as they get bigger, they can cause headaches and peripheral vision loss. Treatment. The first line treatment is surgery. We'll go into what that surgery is. Except we have one exception, and we'll be able to remember this on a test. Exception is prolactinoma, right? If you have a prolactinoma, what first line is medication? So you think prolactinoma, prescription pill, or you just are smarter than me and will just remember. Okay, so prolactinoma is the exception where we're going to try meds first, prescription first. There's also radiation therapy, but we're going to use that's third line. Okay, we're going to use that not as often because it just comes with more risks, and you'll see that shortly. All right, so that's the generalized treatment for adenomas. We're going to go into those three, I guess technically four, one by one. So, lactotrophic, what does that mean? Say to you, lacto, milk, right? Trophic has to deal with nourishment, but in this case it has to do with like cell growth. So kind of think of in cells promoting growth. So we have what's going on here? Lacto, what's this person maybe gonna have? Yeah, so maybe some milk secretion from their nose, right? So prolactinoma is another term. I usually use prolactinoma all the time, but it's technically a lactotrophic adenoma. Prolactin secreting adenoma. So prolactin itself, we need it, right? Especially women, we need it for lactation, milk production, for after baby comes, right? So the regulation for prolactin release is a little bit different. So we have prolactin releasing hormone, which you don't need to memorize, but dopamine is your inhibitory. So if we didn't have dopamine, this would be continuously excreted, but thank you dopamine for coming in. So do these names look familiar? These dopamine agonists?
Nope.
A little bit?
Oh, yeah.
We're going to talk about it. So if we know that dopamine inhibits prolactin, if I have somebody with a prolactinoma, I'm going to use these meds, okay? Okay, so normal secretion. So obviously this makes sense, right? Pregnancy and breastfeeding is going to cause prolactin to be released. Nipple piercing, breast augmentation, any kind of breast surgery, stimulation to that area can also cause prolactin to be released. How weird is this? Exercise, specifically REM sleep and stress also, right? Very non-specific things that we're all, maybe you guys aren't exercising as much, but we all do. And then chronic chest wall stimulation. Who in the military might have some chronic chest wall stimulation? Part of their job, maybe something you wear.
Rocks.
People with light carriers.
Yeah, like if you're, for the Air Force, it's the security forces, right? They're wearing plates in their armor. The armor's changed a lot more, so we don't really see people coming in complaining of these types of symptoms, but in the past, like old armor and stuff could cause chronic chest wall stimulation, and then they would release prolactin and have come in with galactorrhea. So that's normal. Abnormal causes. We got prolactinoma right there in the middle, right? An adenoma that is secreting excess prolactin. But wait a minute, hypothyroidism, right? That's where we tie in that cross-reacting hormone. Again, that's that TRH. It's the precursor for TSH, which tells the thyroid gland to produce more thyroid hormone. In some patients, can also kick up prolactin. Okay, so that tells me if I have somebody that is presenting like they have a prolactinoma, what do I need to also work up? Hypothyroidism, right? And if that's what's going on, maybe I should treat that first. Okay, and then any kind of pituitary stalk lesion. The first two that I care about. All right, so prolactinoma, again, it's benign tumor. 80% are functional, so 80% of the time they're producing some kind of excess prolactin. And if I have excess prolactin, what is going to be inhibited? LH, right? What does LH do later down the road? So if LH is released from the pituitary gland, what is it important for males and females? Lots of things, right? Yeah, it's a gonadotropin. It's that pathway. So that will be really helpful with our signs and symptoms, okay? Let's jump into signs and symptoms. So if I have a premenopausal woman, they're going to have menstrual cycle irregularities. They're going to make that, maybe that's what brings them in, right? My menstrual cycle was normal, and now it's not. So amenorrhea is lack of menstrual cycle. Oligomenorrhea is like more infrequent. Okay? Infertility, for sure you're checking prolactin on any patient who comes up for infertility concerns. Galactorrhea, we know what that is, right? Spontaneous milk secretion. Not related to breastfeeding, right? I've never had a baby. Oh, they're a man, but anyway, this is a female. Never had a baby. Why do I have lactation? And then LH deficiency. So when women go through menopause, their LH and FSH changes, and they start to get these fun menopause symptoms or perimenopause symptoms: anxiety, depression, irritability. They'll have vaginal dry illness, low libido, skin changes, increased risk for osteoporosis when you have estrogen drop. So this is again a young woman shouldn't necessarily be presenting like this, and it's because that excess prolactin inhibits the LH, which then affects the estrogen, progesterone. Okay. And postmenopausal women, it's a little bit tricky. They're already dealing with the low LH. So they might not have. They're used to all this anxiety, depression, irritability, and stuff. They also rarely have galactorrhea. So you usually don't catch them unless they're having like the mass effects, and maybe a larger adenoma. So they'll come with like headaches and the visual changes. Okay. Now, what about guys? What do you think they're going to present? Maybe there's some similarity, right? Gynecomastia, galactorrhea, decreased libido, erectile dysfunction that doesn't respond to ED medication, headaches, visual disruption, and infertility. Okay, so what of these are caused to that low LH? What do you think? LH impacts testosterone later down, right? Yeah, Leydig cells, all that stuff. What libido, right? What's going to bring a guy in? Is it going to be his headaches? Maybe. Or is it going to be the decreased libido and the erectile dysfunction? Just like with women, maybe it's their menstrual cycle, or they don't come in until they are trying to get pregnant and they can't, right? Some patients come in with the tiniest little thing, and then others wait. So again, it's the LH symptom, the LH inhibition that usually brings your male patients in. And then you have your mass effect, right? Your macroadenoma, and that's the headache and the visual disturbances. Now, 90% of males with prolactinomas are over a centimeter, right? They're macroadenomas. Is that because they just ignored the symptoms for a while? Or is that, because it was mild, or maybe they had their ED meds, or they just thought it was because they were getting older, dismissed it for something else? I don't know. But again, most of the time, if you have a male patient with prolactinoma, it's going to be a macroadenoma. Does that help kind of tie in the cross-reacting hormones, hopefully? For males and Okay, so we get a good history. We're concerned this person might have some excess prolactinoma. We do a physical exam, signs and symptoms. What do we do next in Endo? Labs, right? So labs. So let's go ahead, and this is underlined is what you need to know. You need a serum prolactin, right? Because we're going to assess what we think is in excess. TSH and free T4. Why do we need that? Right? We need to rule out a thyroid disease. That could be a hypothyroidism. Could be the underlying cause of this high prolactin, and then a CMPT. Okay, cool. Additionally, you're also going to check a pregnancy test on a female, right? Because what else could cause someone to have excess prolactin, right? Prepping for baby, right? You always want to rule out pregnancy. And then you're also, I don't test you on this until the next block, but you also need to check testosterone, LH, FSH, estradiol, right? You need to check those gonadotropin hormones as well. But the underlying stuff is what I need you to know. And in block 2, it all comes together when we talk about ingredients. So serum prolactin, it should be less than 20. But wait a minute, so it says don't check right after a breast exam. Why? Right? So we do a breast exam on this patient. We're causing chest wall stimulation. We can cause it to normally elevate. And then it's FYI that biotin is an interesting hormone that, or supplement. It messes with a lot of hormones. So it was in current and it's a thing, but that one is FYI. So if I have an elevated prolactin, I need to repeat it because it's a hormone. We need at least 2 elevated prolactins before you move forward with your MRI. And then if I have a high prolactin twice, it just says that you might also want to consider is there any other hormone deficiencies. That's just FYI. I won't do that too. RADS make sense, right? We have excess prolactin, thyroid hopefully is normal. I'm going to do an MRI to see if there's an adenoma. Any questions on that? So this, yeah, that's a big, this is where the problem, okay, here's normal, and then there. That's a macroadenoma. It's no good. More likely in male. More likely to have the low libido, erectile dysfunction, the headaches, and visual changes. All right, so treatment. First treatment. You said prolactinoma is prescription. Oh, yeah. I would just have them do it the next day. Yeah. Because usually you don't have to do them fasting, and so you do the breast exam, usually send them to lab. Just have them do it the next day or when it's convenient. And if they can't, maybe you can have them go get lunch and then come back. But you're going to repeat it twice, so for sure the second one will not be correlated to a breast exam. All right, so underlying treatment, our underlying problem first, right? If the TSH or free T4 indicate hypothyroidism, we treat that first. All right? So if we treat the hypothyroidism, what will happen to the prolactin? It'll go back to normal. Because why? Because the TRH goes back to normal and stops excessively stimulating prolactin. Okay? So we're going to treat that, and we'll learn how to treat that in lesson 4. And then we reevaluate. Reevaluate in 6 to 8 weeks. See, and I would be checking both the thyroid and prolactin. So treat the hypothyroidism, the prolactin should fix itself. And if they're on any medications that are known to cause high prolactin, you obviously change that. But this is endo, not pharm, so we're focusing on what prolactinoma and the thyroid. All right. So again, this is why we're treating hypothyroidism first. Okay. But let's say the TSH was normal, and we do an MRI, and it shows an adenoma. We're going to do prescription, right? Pharmacology first, pill first for prolactinoma. And this is where our dopamine agonists come in. And if we get stuck, we can go back to physiology, right? The dopamine is an inhibitor of prolactin, so we're going to use that knowledge and give a little prescription of capercaline, bromocriptine, either one, okay? And I think this is cool. We give a medicine, and 85 to 90% hit normal prolactin levels with this medicine. That's pretty cool. A lot easier than a surgery, right? Not only that, but 50%, you get a reduction in the size of the adenoma by 50%. Super, super cool. Can improve infertility and probably all those symptoms that they came in for. are potentially going to improve. What, does anybody remember the side effects of dopamine agonists? Have you learned that yet in Park? Yeah. Yeah. So you could essentially just, they have to take it at night because it can cause like nausea, dizziness. Also, you have to watch for your psych patients. It's not on the slides. This is not to be on the test, but depression, anxiety symptoms, impulse stuff. So they can be like have impulsive disorder, hypersexuality, all kind of weird symptoms. So if you have a patient, you try dopamine agonists and they can't handle it because of those side effects, then you would go to the next line, next course. So first line's prescription. What do you think is second line? Surgery. Yes. So before we go into surgery, this is one pre and post prescription properculine treatment. So here it is, and so this person's is a male, macroadenoma over 1 centimeter. He presented with headaches, but he had normal vision, so I hadn't messed with his peripheral vision yet. You see this? I mean, I could catch this. Don't worry, I will not put an MRI on your test and be like, what is this? No, I don't do that. But, so they give him properculine. Before that, his prolactin was 8,000. Normal is less than 20. Insane. So, 2 doses, 6 months of therapy. Look how much better things are. Much better. And then his levels went down from 8,000. Did I really say 8,000? Yeah, 8,000 to 15. 6 months. Pretty cool. But maybe he's unresponsive to meds. That didn't work. They can't tolerate the medication. Just because the textbook and I tell you it's first line, what is a main driver of treatment? What's another component of treatment? Patient preference, right? It's shared decision making. So even though sometimes the test says surgery is first line, maybe it's surgery plus meds, right? So just there's a clinical component of this. For whatever reason, we go to surgery. Especially if it's like significant headaches, visual changes, that sort of thing, we're going to do a transphenodal resection. I'm going to come right back to this side. So here's a transphenodal resection. Is anybody, I get real nerdy about this, like, who the hell thought of this, right? Who the hell is like, oh, I know how we can get to the pituitary gland. Who wants to guess what year this surgery was first done? 19, what? You got 19.
1892.
Later. I like the 19th.
1915.
1920, lower, earlier. 1910, so close. 1907, by good old Dr. Schulfer. Yeah. And then Dr. Cushing, which you guys are going to hate Dr. Cushing soon, but Dr. Cushing is the one who mastered it. He performed it 2 years later, and by 1927, it was like, they got it figured out. This is how we do this surgery. When did they start washing their hands in the OR?
Later.
1889. So at least it was after that, but still, it's just blows me away. Anyway, okay, so we do the transphenodal resection. Obviously, there's risks that are associated with it. Look at this. DI, diabetes insipidus, can concur post-op. SIADH can concur. So we're overlapping a tiny bit with what we learned yesterday. All right. And then third line for this would be radiation. We rarely use it. There's a greater risk for pan-hypopituitarism. We'll talk about this in just towards the end, but just the name pan, which is like the entire hypo, which is low, pituitarism, right? So that means it's affecting a lot of hormones. So I'm going to treat your prolactinoma, but I'm going to give you this radiation and screw up all these other hormones, right? So that's why we don't like it. If we can avoid it, we're going to try pills and surgery. Overall, these patients do really well. You're going to monitor them. And then if a patient does not want to do any treatment, maybe you find this incidentally, like they came in for something and they need a brain MRI. The brain MRI picks up this adenoma on, say, a female. She's like, I feel fine. I don't want any meds or anything. You have to screen them for osteoporosis because remember, we're depleting their estrogen. So when we deplete the estrogen, they have an increased risk of osteoporosis. Same with males, okay? So that's a big thing. Questions on prolactinomas? Oh, when did I start? Where am I at? So I need to pause, when? 35? somato means body, trophic, so we're talking about growth. Growth hormone secreting adenoma. Second most common, 15% of these guys can also show up with a prolactinoma. How fun is that? So you can have two. Here's your negative feedback loop that we're also familiar with. We start with the anterior pituitary. It releases growth hormone, goes to the liver. In the liver, growth hormone is secreted to IGF-1, insulin-like growth factor, and then that goes to all the target tissues. Okay. Once levels are where they need to be, you have the negative feedback loop that kicks up and says, "Hey, we're good. You can stop losing." Here's the verbiage of this, if you like that better. Growth hormone is so important, right? I'm not going to go into the details of all of why growth hormone sounds great on paper and why we need it, but it's important, right? It's in the name, growth, right? We need it to grow for longitudinal growth. It impacts like gluconeogenesis, lipolysis. It affects our mood, metabolism, all sorts of things, okay? Nuts when we use it normally, right? And so we have a lot more growth hormone at the beginning of life, right? And then as we age, growth hormone decreases. Does anybody remember the baseball player at the top?
Barry Bonds.
Yeah, in the 90s, there was like the home run derby with him. I forget the other guy. Anyway, so it was a lot of controversy because he wasn't just using testosterone, but also growth hormone. Okay. You could maybe see a little bit of difference in his face and stuff like that. So, all right, it's stimulated. Growth hormone is tricky. It's stimulated by sleep, but also by exercise and illness. So very non-specific things. It's inhibited by somatostatin, hypothyroidism, steroids. Obviously, the IGF-1 makes sense. This isn't like a slide you have to memorize, but specifically the bottom is going to come into play when we go to labs. That hyperglycemia, so when our blood sugars go high, that naturally inhibits growth. Okay. I already said this. It's maxed out at puberty when all the growth and all the fun things are happening. And then it declines. But what is this? A pulsatile manner. So I tell you, so growth hormone usually, you'll have more pulses or more surges at night. But you have them throughout the day, 8 to 12 pulses per day. Does that mean it's predictable? Probably not, right? If it's sleep, if it's exercise, if it's illness, right? So that's why we can't, especially when we're thinking of excess growth hormone, we can't just do growth hormone lab. So it's really important to understand that this is a pulsatile hormone, hard to predict, right? Is it easy for you to tell your patient, all right, I need you to get your lab done, we have to watch out, sleep will trigger this, and stress, right? Who can take away stress in your So again, it's tricky. It's a lot easier when it's deficient, but when it's in excess, we have to get creative. We will learn how to do that. All right, so there's two types of somatotrophic adenomas. When you're a kid, it's gigantism, right? It's prepubertal, so you're going to grow. Versus acromegaly, which you guys identified yesterday, and that's when it happens when the growth is done, right? Your growth plates have fused, you're done growing in height, so other things grow. Your soft tissue, skull, your hands grow. It says internal organs enlarge. Do you think that would be a problem? Yeah, especially the heart, right? Yeah. So don't forget about that. All right, so gigantism. So this is Robert Wadlow. He's a famous gigantism guy. So at 5 years of age, he was 5'4". By the time he was 8, he was 6 foot. Yeah, and by the time he was 21, he was 8'8". It's wild, right? So this isn't what killed him. It wasn't like a cardiac thing. It was, they were more prone to infection, and he had a blister, a septic blister from an ankle sprain or something, and that's what he died of. But that's gigantism. Pediatric, that's all I got for gigantism. We're going to focus on acromegaly. So this is a female over 9 years. What do you notice don't read the MRI, but what do you notice in her face from 1997 to 2000?
Wider.
Stronger features.
Yeah, her feature. Now, is that just normal? Wow. But look at her. I mean, she has her hand there. A lot of times with acromegaly, you're going to see people with their hands. But what if, like, maybe her cheeks have gotten a little bit bigger, her nose, the fleshy nose. It'd be nice to get some vitals on her, weight, BMI, all of that stuff. But if you met her in 2004, between 2004 and 2006, there's not as big of a difference, right? So you can see how it would be tricky if you don't know your patient. And because it's a very gradual process a lot of the time. So if it's gradual, do you think we catch it? Are we good PCMs at catching this? Or not? It usually takes 10 years before somebody gets diagnosed with this. And then you can see her MRI. She had a lot of times growth hormone adenomas are macro. But there's her adenoma. Okay. This, I think, makes sense, the signs and symptoms. So widened hands and fingers, so their hands get bigger. So they're not going to come and be like, my hands are bigger. No, they're going to notice when their ring stops fitting, right? They have to change their shoes or their gloves. We expect that in our kids, right? Every year you have to get them new tennis shoes, but in adults, not so much. Hyperhidrosis of the palms, that might be a harder thing for them to come in for, but it's common. Carpal tunnel syndrome, why do you think they come in? What causes that? Excess growth hormone. So that soft tissue, or that's the bone, right? So it could be either, but usually it's the soft tissue. And then of course these classic acromegaly coarse facial features. This is like co-arc, right? Acromegaly is kind of nice because it's very specific to that. But it's frontal flossing, which is that the forehead is more prominent over time, right? It's not overnight. It's overall crazy. The large fleshy nose. Their tongue gets really big. Proganthosm is where their jaw will shift forward, and then malocclusion, their teeth don't line up anymore. Okay. Here's just like a diagram of comparison of all the things. If you like pictures better, here's real people. The frontal flossing, the proganthosm, and then I guess if we really looked at his teeth, we might see the malocclusion, and then you have like kind of the fleshy. Do you see how the woman, it's not as obvious? Right? Like, maybe that's just how she looks, but if you looked at, say, a driver's license picture from like 8 years ago, maybe you would see the difference. And then here is, again, the classic hand changes, normal versus abnormal. This one is the same person, so it's not as helpful. What do you think of this guy? Do you guys notice anything funny?
Two left hands.
Yeah, two left hands. So that was in the slides, and I left it because I think it's super funny. So, because obviously it's a different person, but it's to exhibit acromegaly versus not. But yeah, no, it's like that's not the same person, but it's funny. All right, but again, so we have these coarse facial features, but what about internal organs? PCMs, primary care. This is you guys, right? Endo's gonna fix the problem of the adenoma, but guess who catches it? Guess who screens them? You guys all day. So cardiovascular risks. They are a higher risk for heart failure. 50% will have hypertension. Guarantee they have hypertension usually before you're diagnosed with acromegaly. Cardiomegaly, sleep apnea. Why? What do you think about that? You've had pollen. Yeah, obesity, and then just the soft tissue, and maybe the jaw changes, right? All of these things add up. Diabetes, insulin resistance, absolutely. Weight gain, headaches, joint pain, arthralgia is really, really common, and that makes sense, right? We're seeing all these changes in soft tissue. We see the hands actually growing inside, like that makes sense. Erectile dysfunction, colon polyps, 30%. So if I know 30% of people with acromegaly have colon polyps, what am I doing when I diagnose them? Colonoscopy, right? Maybe an echo, an EKG, rolling them, working them up for diabetes, screening them for, make sure like they're not high blood pressure, all of that stuff, okay? So it's the fun endo thing with the adenoma, but there's a lot more to it. And this is the progression. This one's like significantly different, right? From the nose, and then it's that hand pose that they do. Significant changes. But again, if you didn't know this patient between 16 and 33, you might not notice. All right, so we do a physical. We get a good history. We're concerned. We do the physical. We see all these physical findings because we actually touch and look at our patient. And Now it's time for labs. So we can't just do a growth hormone, right? Because it's pulsatile, it's hard to predict. So instead, we're going to use the IGF-1 level. Okay? We get a random IGF-1, and if it's high, we're like, sweet, I'm in the right direction. I need to repeat it fasting. Okay? So we have a fasting, and then we have to do our specific endocrine test. So oral glucose tolerance test. Do you guys know what that is? Essentially, like pregnant women will get it, or it's also used for diabetes. But we give somebody this gross, super syrupy, it's like orange or grape. It doesn't taste like orange or grape. It just tastes like grossness. And you give them sugar, and then you see what their blood glucose does 2 hours later, right? But in this situation, we're going to give them that gross glucose syrup, and instead of measuring glucose, we're going to measure growth hormone. Because we know that hyperglycemia should inhibit growth hormone. So in you guys, if I check your growth hormone should be low. But in someone with acromegaly, what happens? Growth hormone stays high. Okay? We're trying to inhibit it. We're inhibiting it, but what's the problem? The problem's up here. The adenoma doesn't care, and it's just kicking out excess growth hormone. Okay? So this is your confirmatory test. So it's nice. I think I added color. Yeah. Confirmatory test is your glucose suppression growth hormone. And again, I added this of why can't we just check the growth hormone? We can't when it's just not it's not an accurate test when we're checking for elevated. Why are we ordering a prolactin too? 15% of these people also will have a prolactinoma or excess prolactin in the same adenoma, okay? MRI all day, right? You know that, it's easy. This differential, we can skip that. How do we treat this? An adenoma, growth hormone, secreting adenoma, acromegaly, surgery. Our nice new transnodal resection, treatment of choice, right? We only need prescription first for those prolactinomas. 70% of people do really well. When I take this adenoma out, their growth hormone's going to tank, so they're not going to feel super great. And a lot of times we have to give them a little bit of steroids too, because we're messing up kind of that HPA access when we do it. And oh look, the lingering DI and SIADH are right there potentially too. All right, so maybe this patient doesn't want surgery, they'd rather do medication. Well, we have options for that. Specifically, the somatostatin analogs, they're going to inhibit growth hormone secretion and decrease that tumor size. So again, so we're going to recommend surgery as first line, but it's not a good surgical candidate or there's risk, you can do a somatostatin analog. Again, that's first line for non-surgical patients. Dopamine agonists can be effective, even in patients that have normal prolactin levels. Sometimes they'll do this after surgery. And then the rest of just FYI. It's mainly because growth hormone receptor agonists are super expensive. I'm not going to let you prescribe them, but it's just the top two that make a difference. Okay. Radiation we're rarely going to use, right? We don't want to cause that hypopituitarism risk. And the last slide on acromegalia, we have the surgery or we do the somatostatin analog, and we have to monitor them, right? We need to make sure that nothing is coming back, so we check their IGF-1. And then the cardiac risks, right? We have to manage their 50% of hypertension. Endo isn't going to manage their hypertension, that's you, right? So we want to prevent any of those cardiovascular disease risks. We need to send them for a sleep study. They need a colonoscopy, right? An echo, an EKG, all the labs. So yes, we're going endo, but we need to take care of all of that stuff as well. And then we tell, hey, once you have the surgery, I'm sending you to endocrinology. You teach them what an adenoma is. You tell them what their options are going to be. You send them to endo, and you say, hey, usually patients do really well, and all this soft tissue stuff should improve. But unfortunately, that skeletal stuff doesn't change. So it's harder to adjust the bone changes. And usually what stays around? The hypertension. OSA usually lingers for a lot of these things. Okay, we'll pause there for 10 minutes. See you guys
Just Yeah, I don't
We're just some Adderall.
okay. Buy one. Yeah, no, I won't eat out of it. And it's like hot as summer, and it's like 40 degrees in here, and you're freezing your ass off. Better to see here, it's freezing.
I'd rather have a big cold than a jacket.
They're down running grass.
We do like more versus natural. And I got very
Husband's actually I met him. Whatever it was. He got caught. And he got kicked out. They just pick up and they say, oh, he's got kids, but it's cute. For him, I don't know if there's like a thing. He was an ER. It's crazy. That's why I go with my wife. That's like so much talking. Yeah. Challenge accepted.
Got it. No, that's fine. I'll have to but I would leave yeah. I kind of but
So, we talked about hypothyroidism
yeah, it's super rare. Okay. So you learn in school about secondary hypothyroidism. Ever see it? That is textbook. It's so rare, yeah. But yeah, and even the TSH active ones, it's so rare, like it's not even percentage range is so low. But yeah, and most of the difference too isn't a proactive. They're collecting not always, but like 8,000. I mean, it's still high, but you still, but I don't put that on there because I'm overthinking it. I just want you to know it's lectin's high. I'm concerned about it. Always check that. Thyroid not check that first. So, and you can be treated with thyroid but the labs are off. I can start treatment now.
Got New York. I don't. You got a felt rebel?
Just jump in as you guys move to your seat. You have tomorrow off. Hey, tomorrow study day.
Not all. Yeah, we're gonna be studying.
Okay, no traffic. Okay, so then third item we're going to talk about is your corticotropic ACTH secreting. What is ACTH if it's released from the pituitary? What's its target gland? Adrenal cortex. We have a whole lecture about adrenal cortex and then another lecture about adrenal medulla. But the end result here, when ACTH is secreted, we get cortisol. So if I have too much ACTH, then what will I end up having? Too much cortisol. Okay. So again, excess. So third most common, we see it much more common in women, and typically micro. Now I'm going to pause here. I'm going to say this. You're going to not like it, but I'm going to say it so much during this block that it's going to come together. And then the review, we're going to draw it out and it will come together. But Cushing's syndrome, all that tells me is it's equivalent to hypercortisolism. So high cortisol in the blood. Okay? Cushing disease is also known as ACTH-dependent hypercortisolism. So we used to say Cushing disease and Cushing syndrome. You'll still see that, but they had new nomenclature. Anyway, ACTH dependent. So what that tells me is that it's ACTH causing the high cortisol. Okay, so if you break that down, ACTH is the driver of the high cortisol. So let's do this again. Cushing disease is typically 90% of the time, it's a pituitary adenoma in my dome, in my brain. Cushing disease, 90% of the time, it's an adenoma in my dome, and that's ACTH dependent. They'll help you as you study. So again, Cushing disease is what we're going to talk about today, because 90% of the time, it's going to be an adenoma. 10% of the time, it's an ectopic source, so like a tumor somewhere else. And we'll tie that all in together, all of it, in less than 5, okay? So, just a quick feedback loop, remember. So we have your hypothalamus releases corticotropin releasing hormone. But again, I pay attention to the anterior pituitary. It releases, when cortisol is low, it's going to release ACTH into the bloodstream. It goes to the adrenal glands, specifically the cortex, and tells those adrenals, we need cortisol. And androgens a little bit too, and other things. But we need cortisol, and cortisol is released into the blood. Okay? Homeostasis is reached, and then we have that negative feedback loop. Okay? So this is our axis. So here is what I'm saying. So Cushing syndrome is this overall term for high cortisol. Cushing disease is the problem is in the dome 90% of the time. Cushing syndrome is the problem is in the adrenals. Annoying, I know. And I give ortho such a hard time. This is all named after Dr. Cushing. I give ortho a hard time because they have all the names named after all the different surgeons, and it annoys me. But here's our annoying one. So clinically, they look the same. So what does that tell me? If physical exam and medical history are likely going to be the same, what are we going to have to lean on to get the diagnosis? Labs and then eventually imaging, right? So labs and imaging. But bonus, if they present the same, then you only have to learn one thing, right? It's the same for both. Okay, all right, so this is how they present. Excess cortisol, they're going to be tired. Everyone with endocrine disorders are tired. Central obesity, so that kind of like the Santa Claus belly. Do a lot of people who are obese, specifically men, kind of have central obesity? So you can see how it's. Do you think Cushing disease is more common than obesity? Or is obesity more common than Cushing disease? It's obesity. So most of the time it is just obesity. But what do? We're going to listen to our patients. We're going to actually do a physical exam. And we'll give you some cases where you're going to be like, oh, I can see how that got missed. So you're going to be a better PA, right? All right, so central obesity is one piece. But we need multiple pieces, right? Plethoric moon face. What is plethoric? I think it means like redness. So plethora, redness. Moon faces, they'll have bigger, like kind of moon face around their cheeks. Do obese people sometimes have excess skin, right? Yeah, so it's a little bit harder. But usually they're going to have like a redness. Buffalo hump. So that's that dorsifcervical fat pad back here. So we need to do a physical exam, right? You can also have fat pads along the clavicle as well. So thin extremities with muscle atrophy and proximal muscle weakness. So a patient's not going to come in and say, yeah, I have proximal muscle weakness. I think I have Cushing's. What would they, how would you get to this? Proximal muscle weakness. So you can do a physical exam. And they might have like kind of like thinner muscle or atrophy, or they might have trouble getting out of the car. I have trouble getting myself up from the floor when I'm playing with my grandkids or my kids, right? So simple daily chores that they struggle with because they lose that proximal muscle strength. Purple striae, what's that? Yeah, stretch marks. And most stretch marks are like flesh or skin color, just a little bit darker, but these are very dark and purple. And I'll give you some examples. Easily bruising and delayed healing, that's related to that excess cortisol, which we'll dive into more in lesson 5. But that's a problem. You guys will see, you'll see different phases of bruising or ecchymosis on these patients. Menstrual cycle irregularities, erectile dysfunction, and they're prone to infections, right? Prone to like fungal infections, bacterial skin infections, that sort of thing. Acne, a lot of patients will have acne. And again, it's not just acne. Oh, you have Cushing's, it's all other like the cluster of symptoms, right? Osteoporosis. Excess cortisol will diminish the bone density, so these patients get osteoporosis. So we'll learn in lesson 12 that you screen women for osteoporosis. But the minute a man has excess cortisol, we're screening them with the bone density. Okay, so we have to watch for osteoporosis, and that's because that excess cortisol impacts the bones. Mood symptoms for sure are impacted, and then high blood pressure. So Cushing's hypercortisolism is a secondary cause, or it's a cause for hypertension, secondary hypertension. Okay, it's not as common as others, but it's up there. So patients who just think they have high blood pressure and they're harder to control, or they're young, like, and you do a physical exam, and you're like, oh, you have a buffalo hump, and you have this, and you have that. Maybe you think Cushing's. And then they're more at risk for type 2 diabetes, insulin resistance, and that sort of thing. Questions? Here's a picture of this little guy with Cushing's. Again, it goes into even more signs and symptoms. Here's your purple striae. And it'll be like in the abdomen a lot of the times, the side. So you have to what? Remove their shirt to catch this. Okay. What do you see on this little guy, or this little guy? This diagram here.
Buffalo.
Yeah. You know, it's so funny. So, oh yeah, buffalo. But look at this jawline. Is this a Cushing's jawline? No. It's like all thin and no. But anyway, there's your buffalo. I really need to update the pictures, but I like the funny ones. All right. So we have a patient come in. He's an 18-year-old. He's coming in complaining with depression and low back pain secondary to vertebral fractures. Also, he's had a 20-pound weight gain over 2 years. So 20 pounds over 2 years, probably not crazy. 16 to 18, though, usually you're not gaining a lot of weight there, but what do we have? We have a child, like a pediatric obesity problem, right? So you can see how that could have been missed. But should an 18-year-old have vertebral fractures? I don't know. What do you notice on his just physical exam of his face? Yeah, maybe some mood changes. Is that redness? Maybe there's some acne, right? Well, can we just say like, I'm sorry, man, I'm gonna kick you to ortho, and they're gonna give you some supplements or something to figure out why your bones are so weak, or do we do an actual physical exam? We listen to his heart, we make him remove his shirt, and then look. There's some central obesity, specifically, maybe we see some proximal muscle weakness with the exam, and then of course that purple stripe. So you catch it, you listen to your 18-year-old patient after 2 years of just being like, you're fine, exercise more, and look, you treat him. This is 1 year after you remove his pituitary tumor through surgery, and look at him. Now 19, the purple striae don't go away, but significant improvement. Now you don't have to worry about osteoporosis. You still might need to monitor him for hypertension, but because he's so young and he's had the weight loss, it probably is managed well. So, physical exam, we've got that. Very classic signs and symptoms like you see in acromegaly, but now we need to do labs. And cortisol is released in a diurnal pattern. So what does that mean, diurnal? So it's released more at night. And so we use that to our benefit and in our testing, okay? So in your initial lab, so I have someone with Cushing's based on all these signs and symptoms, the plethora, central obesity, the acne, the striae. I think you have Cushing's disease or Cushing's syndrome. We'll stick with Cushing's disease because that's where we're in. I need to do labs. I need to confirm if you have high cortisol in the blood. And you need it to at least have 2 out of these 3 labs have to be elevated. Okay, you don't have to do all 3, you can just do 2. And in MTFs, it's harder to get the salivary test in our clinics. But we have these 3 labs we're going to do. So, dexamethasone suppression test tells me right in the name what it's going to be doing. What's dexamethasone? It's a steroid, right? Okay, suppression test. So, if I give a patient a steroid at night, so give a patient a steroid at night, increasing what? That cortisol, the steroid level in the blood. What should ACTH do if I give someone a steroid? Should decrease, right? Negative feedback. Cortisol pumped up, it should decrease. And then if my ACTH goes low, what should my cortisol be in the morning? Low, right? We'll walk through this again. In these patients, it's not low. We expect it to be low. We're suppressing it. but it's not. And so it shows that their cortisol's, if it's still increased, then I'm suspecting hypercortisolism. Okay? And I need to also do you can also do a 24-hour urine, right? We talked about that yesterday. And we're checking for cortisol. And if that's high, that helps confirm, not Cushing disease, but it helps get us to that hypercortisolism. And then the late night salivary gland, and so this one is weird. So essentially they like spit in a cup at like 11 o'clock at night, and they have to repeat it a bunch of times. So you can't like brush your teeth, you can't like drink certain things. There's certain things you have to do before you rinse your mouth and spit in this thing. You have to do it multiple times. But again, if you have 2 out of 3 of these are elevated, then what do we know? We know you have hypercortisolism, so I can go to the next step. All right, because dexamethasone is kind of tricky, we're going to walk through what happens in a normal patient. So again, you give someone dexamethasone or they take it at home. This is a very easy test to do. They take dexamethasone, they take the pill at night before bed, at 11 o'clock at night. Because of that excess cortisol in the blood that I gave to them, ACTH, negative feedback loop, will make less ACTH. We're going to have less ACTH. Therefore, the adrenal glands will make less cortisol. And when we check the lab, what do we expect it to be in the morning? Low. Okay? Low. And again, if cortisol is normally diurnal, it's harder to control that because at 8 a.m., the range is harder to control. So that's why we do the suppression test. Versus a Cushing disease patient, I give them steroid. ACTH is the pituitary is supposed to make less ACTH, and therefore the adrenal gland should make less cortisol. But in a Cushing disease patient, we have more cortisol because where's the problem? 90% of the time, this is adenoma in the dome, Cushing disease, causing, it doesn't care, it's working outside the negative feedback loop. It's doing its own thing, taking out extra ACTH, and therefore the adrenals are just doing what they're supposed to be doing, creating cortisol, okay? Hopefully that makes sense. If it doesn't, we'll hit it again in lesson 5. And then I'll draw it out with a silly stick figure and hopefully you remember. This is a nice summary. We'll get into Cushing syndrome later, but normal versus Cushing disease. All right, so I did my 24-hour urine. I did my pooled dexamethasone suppression test. Both were high. I know this patient for sure has high cortisol in his blood. So now I need to go to the next step, and I need to confirm it with plasma ACTH. Now, you don't need to know this for the test, but the blood test, the ACTH blood test is very finicky. There's all these weird rules and all these things with it. I don't know how much it costs. I should probably look that up. But this is your confirmatory test to tell me, is this Cushing disease or is it Cushing syndrome? So when I do a plasma ACTH, it's high. Does that make sense? Okay? High because it's the adenoma causing high ACTH, okay? All right, perfect. DHEAS, I think in like years from now, instead of ACTH, I'm going to be saying we do a DHEA lab instead, just because they mimic each other. That's FYI for now. It's just like a more stable lab. But again, it's plasma ACTH. And I'll summarize this in lesson 5 too. Okay? MRI for sure, we already know that. Treatment, surgery, right? Or transfemoidal resection surgery. Sweet remission rates, 80 to 90%. That's pretty awesome, right? We still have to monitor them after we have the surgery, right? For DI and SIADH. Well, I have this bolded in purple. They need replacement steroids for anywhere from 6 to 36 months after recovery. Why? Right? They just had an adenoma that's producing excess ACTH, so the adrenals are producing excess cortisol. So are they they're not operating in a negative feedback loop. It takes a really long time for that HPA axis to get back to normal. Okay, so you have to supplement with steroids. Wait, what? This person had excess steroids and I'm going to give them excess steroids for a short period of time because you wiped out their pituitary function, essentially. And it takes a while for it to get back, so these people need steroids. If you don't have steroids, you don't live, okay? Get to that in lesson 5, so we have to replace it. All right. And radiation therapy is less common. And yeah, so again, surgery with steroids. Prognosis, they do okay, but again, it's that hypertension We need to manage their diabetes, osteoporosis, right? If it took them a long time, they were told, oh, you just have obesity for years and years. Just because you treat the adenoma doesn't mean that diabetes cures overnight or the obesity cures overnight, right? You're going to have to manage them. And then again, they're still susceptible to the fractures, infections, and things like that. So you have to monitor them for a while. Okay. When to refer, the minute you have a dexamethasone suppression test that's abnormal, we're getting Endo involved, right? Yes, I can still do the MRI, I can still do the plasma ACTH, but we need to get Endo involved. And this is just a reminder, if you look at her, what do you notice? She came in for like fatigue, obesity. She actually came in, I think, for like infertility and menstrual cycle irregularities. And she was told you have obesity, you need to exercise, you need to do that. This is her after treatment. So this woman, I think she actually had to have an adenoma and her adrenal surgery. But again, just a reminder to listen to your patients, okay? It's super rare. This is really rare, but listen to your patients. Okay, that's it for the secreting adenomas. Non-functioning, what do we remember about that? Usually cats and males. They tend to be more aggressive because they get bigger. Same guidelines as far as size. And how do they present? It's not because of excess prolactin. It's not because of acromegaly signs and symptoms, right? It's that usually headaches, visual changes, or an incidental MRI for some other reason, and they find an adenoma, and then Endo gets involved. Okay. Again, if it's small, not producing any hormones, so they don't know they have it. If it's bigger, the macro, then we're going to have signs and symptoms of that space-occupying effect. We'll talk about what pituitary apoplexy, when we start with that, we'll talk about that. So presentation will vary on the size. What kind of labs do you think we do? We can do all. I would check prolactin, IGF-1, maybe do dexamethasone if the exam indicates, do a thyroid, but they're all going to be negative, right? It's a non-functioning. Get the MRI if we haven't already, and then they're going to go to the surgeon, the endocrinologist, who's also a surgeon, okay, and the specialist who deals with this. If it's small, do we have to go to surgery? No, we can monitor them. We educate them on what to watch for, and we can monitor, right? But for sure, we can consult surgeries, and they can talk to the patient too, or consult endocrinology, excuse me. And they can discuss the pros and cons for surgery. But again, yeah, if it's small, they're asymptomatic, we can just monitor them. That's it for non-function. Non-function is pretty, conceptually, it makes sense. We're totally shifting gears. We're going to end with deficiencies. So anterior hypo, so low, pituitarism. Sticking with pituitary. So it could be one hormone or multiple. And then again, there's that term panhypopituitarism, which is global failure. So for sure, it's going to affect all the hormones. Okay? There's a lot of these, and we're not going to discuss all of them. Okay, I'll tell you what you need to know. But before we get into the specifics, there's just a concept you have to know. Okay, so where's the problem if it's anterior hypopituitarism? Where's the problem? It's in the pituitary, right? So if I have a problem with pituitary, how does that impact the target hormones, right? Both are going to be low. Okay, so let's think about that. So if I have primary hypothyroidism, where's the problem? Primary hypothyroid. It's in the gland itself. So the problem is my gland is the problem. It's not producing enough hormone. My pituitary works fine, so TSH is high, right? TSH, hey, stimulating the hormone. Thyroid works. The thyroid can't work, and it's the failure is here. Secondary hypothyroidism, where's the problem? Pituitary. If TSH is low, by default, what is T for? Low. Because the thyroid gland operates based off the axis, right? So if it's an anterior pituitary problem, both are going to be low. Whether we're talking about the thyroid, I speak the thyroid because it's the most easiest and it's the most common. But if it's the thyroid, if it's ACTH, all of those things, both will be low. Does that make sense? What's more common? especially with the thyroid. What do you think? Primary or secondary? Primary all day. 95+%. It's going to be a thyroid problem. If you see secondary, come and see me. But again, most of the time, it is in the thyroid. It's primary. Okay, so the treatment, you give them what you're missing, right? Again, this is the overall treatment. You're going to give them what they're missing. If it's a growth hormone deficiency, let's give them growth hormone. If it's ACTH deficiency, well, they're going to get glucocorticoids, right? In your Addison's patients, okay? Okay. So, specific etiologies, I pick ones that the PANTS wants you to know, and then I added one that's more active duty related, okay? So the first one is, I think, pretty straightforward. So this was newly added back to the PANTS last year. So you can blame the blueprint for this one. I dive into it a little bit more. So dwarfism or growth hormone deficiency. So you can have congenital, which means what? Born with it, something happened, and maybe you catch it in utero. There's like a genetic issue, right? Or more commonly, you're going to have acquired. Acquired could be to a tumor. Maybe you had a surgery or radiation that made the pituitary stop working, right? So if the pituitary is not working and I'm not releasing growth hormone, you're going to be deficient. Or a TBI. A lot of times, we don't know what causes it. But a lot of times in real life, it's idiopathic. But I'm not going to do that to you, and I'm going to make it make sense, okay? Congenital, again, it's a genetic thing. You might catch it, if it's significant, we'll catch it when they're in mom's belly. Not all of these patients have significant growth delay right out of the chute. It might come up later, but they're going to be jaundice, failure to thrive, and maybe have some signs and symptoms. Okay? But again, the most common, what you're going to see, potentially even in your pediatric rotation, is this acquired, where they have growth failure. This makes sense, right? What's deficient? Growth hormone, hence growth failure, right? So short stature, greater than 2 standard deviations from 4 normal. So what that means is I'm going to skip ahead, and here's your growth chart. So anyone with kids has probably seen this. But we have weight at the bottom, and then you have height at the top. And you have this person, they're right here at 50th percentile in that bold line. And then as they get older, on the x-axis, as they get older, they get older here, we expect them to continue on this progression, but they fall off. This is scary, okay? This is concerning. So when we say falling off, their stature changes, they're not growing as expected, right? During the pre-pubertal and puberty years. They'll have delayed bone age, so we catch that by doing x-rays. And then we always have to rule out other genetic causes that can cause growth hormone deficiency. But again, a lot of times we do not know what's going on with these patients. So we're going to use our growth charts. We're going to get x-rays of their hands. We're definitely getting an MRI, right? Because this is a pituitary problem. We're dealing with low growth hormone. We're going to get all the labs. If I have a bunch of labs listening and I say and more, do you think I want you to memorize those? I don't. I just need you to understand you need to do a full workup for this patient. Endocrine is going to do, they do these growth hormone tests where they use insulin or glucagon and they use these things that stimulate growth hormone to see if the pituitary is actually functioning. Okay? But essentially, really it's you as a PCM, you're going to identify it and send them to Endo. And you treat with growth hormone, right? We're going to give them what they're needed. And that's managed by a peds endocrinologist. Okay. Questions on that? Right. FYI, this is just interesting to me that you have adults around there. One of you has low growth hormone and they don't know it because it's very non-specific, right? Maybe it likes trouble losing weight, they're fatigued, they have concentration issues, depression, muscle mass, all of these things. And maybe it's low growth hormone. I don't test you on it, I just think it's interesting. All right, so we talked about growth hormone deficiency. Now you can also have anterior hypopituitarism due to a disruption in the CNS. This makes sense, right? You had radiation for some reason. You had a pituitary surgery, infection, some kind of cause, disruption up here caused your pituitary to fail. Okay. You guys, I forget you haven't had neuro. The subarachnoid hemorrhage, when someone has that, 50% of them might have some pituitary involvement. And then TBIs. This is the thing I added. So current says 25 to 30% of people with TBIs, traumatic brain injuries, can have a pituitary hormone deficiency. It's probably even higher, 30 to 35. And so why does that matter for you? We're all going to see active duty. You have an increased risk. And there's TBIs we expect. And then there's those men and women who work in career fields where they might have like micro trauma over and over again from different things, from like blasts that we don't pick up on. They can be impacted by this. So essentially, if you have a patient who has a history of TBIs and they're just not getting better, they're just struggling with fatigue and these non-specific symptoms, throw some endo labs in. Check IGF-1, check testosterone, check LH, check thyroid, to see, because it could, again, 30-ish% could have a pituitary deficiency. Okay. Multiple endo labs is all underlined, right? You were gonna, by the end of this block, you're gonna, or especially after both blocks, you're gonna know all the labs what to do. But again, it's just for this one, I just need you to identify that you don't have to know treatment or anything like this, just identify. When I was stationed at Eglin, a lot of our friends were at 7th group, so they were a bunch of Green Berets, and my friend had his assumption, I think it's called assumption, it's change of command in the Air Force, assumption of command. I was talking to a lot of these guys and overhearing them. All these men had thyroid disorder, which is not super common. Yes, all of them were on low T, had testosterone too, which whatever, that was a trend. But thyroid, and then another one had like a stroke, and all these other things. And it's interesting to have so many men on thyroid disorder. What is their risk in common? TBIs. Probably other things too, because they're Green Berets, and who knows all the stuff that goes into that. But yeah, so it's interesting. So don't forget about this, okay? A lot of people do. Now, this one, I'm going to introduce it to you, and it's just, all you have to do on a test is be able to identify it, just like this. So, Sheehan syndrome. The name, she, do you think it's going to affect males or females? Females, right? Okay, so this is essentially what it is postpartum pituitary necrosis. So you have a mom, she goes through labor, and for significant complications, and she has hemorrhage, hypotension, and she needs blood. She loses blood in the delivery, and during that period, there's a vasospasm in the pituitary vessels, and so you can have necrosis and ischemia within that pituitary gland. And the crappy part is they might not present right away. This can present years and years later. So, in the United States, we know about this, right? So if we have a woman who had a really scary delivery like this, then we're know to educate them and to screen them. But if you have a patient from a different country, they might not know this. So Sheehan syndrome is super rare in the United States because we catch it. If you have a patient who gave birth in a different country that doesn't have the same maybe like medical care or options to medical care, they're at risk. And they're going to come in later and they're going to have maybe like amenorrhea, they can't breastfeed, or infertility, and it's this. And they can present really scary with acute adrenal insufficiency, and that's super scary. That's like sick, not sick, that's sick. All right. Next one is, I had you flag this or star it before, pituitary apoplexy. So this is a hemorrhage or infarction within the pituitary gland itself. Typically, it's somebody who has an adenoma. Not everybody who gets pituitary apoplexy has a history of an adenoma. But most of the time, it's hemorrhage or infarction. So if I have a hemorrhage or infarction, it's not going to work anymore, right? So, so this is a very scary emergency presenting patient. Predisposition, this makes sense, right? They're going to have pituitary adenoma, either functioning or not functioning, right? So if I put that in the history, it's probably for a reason. Or maybe I have a history that presents like a Sheehan syndrome, right? Or they have recently had a pituitary type surgery, okay? Increasing risk of, again, that hemorrhage or infarction, sudden death of the pituitary. You have to recognize these patients. This is life or death, okay? And the triad is a severe headache, vomiting, and visual disturbances. What other things present with a severe headache, vomiting, visual disturbances? Yeah, concussion, maybe a migraine, right? Maybe that thunderclap headache that you'll learn about, right? But again, they're not going to be stable. So you might have like, if you have like a patient with their first migraine, they're going to get visual changes in aura, probably nausea, vomiting, and then to them it's a severe headache. But these people, what's differentiates them from like a migraine is they're hemodynamically unstable. They're hypotensive. They're loss of consciousness, weakness. They're sick. Okay. And oh wait, they have a past medical history of a pituitary adenoma. Or they have that Sheehan syndrome-like thing, right? Or they recently had a surgery. So, to treat these patients, you need to stabilize them. We need to give them fluids, right? They're hypotensive, tachy, or even they can be bradycardia. We need to give them fluids, and then we have to treat with glucocorticoids immediately. Now, yes, all the hormones are important, right? We need thyroid hormone, we need growth hormone, we need LH and FSH, all of that stuff. But without cortisol, you're gonna die. Okay, so a medical emergency in this one is treating with glucocorticoids first, and then you monitor them. They go to the OR and all of that stuff. Okay, so that was our one emergency sick patient during this whole block. Okay, so we have all of our adenomas. We know how they present. We got through the labs. We understand the treatment, and then we briefly went through some of the hypopituitary stuff. Not as in depth, okay? Let's apply it, and then we'll get you guys out of here. Okay, so Jennifer Adenomason, she's a 25-year-old G1P1, so that means she's been pregnant once and gave birth once, okay? She has irregular postpartum menstrual cycle for 2 years. We're not an endo. Pretend we're not an endo. What do you think? Maybe some GYN cause or something, right? But hormones play a role, so let's get more information. Her cycle is infrequent. Her last cycle was 6 months ago, but it was really light. She has nice pelvic pain. What's dyspareunia? Yeah, pain with intercourse, no abnormal vaginal discharge or urinary symptoms, okay? She has not stopped lactating since her child was born 2 years ago, even though she stopped breastfeeding a year ago. So she weaned her baby off breastfeeding, but she's still lactating. Is that normal? No. Yeah. With additional review of systems, because you guys are masters of ClinCore, you figure out she has fatigue, irritability, and maybe some cold intolerance. And stuff. So we get a good history. Let's do a physical exam. The vitals are stable. Skin's, I guess, dry but no lesions. You do a breast exam, and sure enough, there's spontaneous milky white discharge, but otherwise normal clinical breast exam, or CBE. Rest of the exam is normal. You definitely do a thyroid exam, heart, lungs, look at the skin, all the things, right? What do you want to do now? Labs. What labs? Prolactin. What else? Thyroid. Not all of them, but which ones? Thyroid. She's a how old is she? She's 25. What should we rule out? Pregnancy, right? Yeah. Yeah. So we do a prolactin, HCG, TSH and free T4, and your CMP. We do an FSH and LH too, but that won't be on the test. What do you see? What's concerning? Prolactin's high, right? What about our TSH and free T4? It's normal. So what are we leaning more towards? Prolactinoma. Yeah. So problemless, not diagnosis. What does she have? Obviously high prolactin. What else? Irregular menstrual cycles what brought her in. She's tired. She's irritable. She's cold intolerance maybe. Galactorrhea. What do you want to do now? We got labs done. Our initial labs. What do you want to do?
MRI.
Oh yeah, where? MRI of the brain, right? Pituitary MRI. And we're going to repeat that prolactin because hormones are finicky and we want to make sure that it wasn't our exam or maybe other cause for the excess prolactin. So you do that. Who wants to read that MRI? Yes, nose goes. I don't want to either. So in the fancy, well-paid radiologist says, hey, your patient has an anterior pituitary microadenoma. What do we suspect? What type of adenoma is it? What type of adenoma is it? Prolactinoma. Great. So how do we treat it? Prescription, or what meds? Yeah, our dopamine agonists, perfect. Ritalin, bromocriptine, and don't memorize the doses. Sweet. And cool, not only are we going to treat her with meds, we can talk to her about surgery, but prolactin levels should normalize for 90% of patients, and the adenoma will decrease by 50%, and it's not even that big, so that's pretty good. All right, next patient is Ned Glanderson. He's a 30-year-old male. He complains of impotency for a year and a half. What do you think? Not endo, like if someone came in with impotency. Yeah, erectile dysfunction. We'd ask all those really personal questions. If you're uncomfortable asking these personal questions, there's also like a questionnaire. You gotta get comfortable and just make it normal for the patient, even though you just. All right, so he admits to weight gain. He's tired, weakness, loss of libido. He's having intermittent headaches. Oh gosh, this guy's a really good historian, and he says he has a decreased vision in both his eyes. Okay. Did your differential from erectile dysfunction change? Yes, but you knew it would because we're in endo. You do your physical. What do you think of the vitals? I guess the blood pressure's like, yeah, hypertension, maybe, but it's isolated, so we need to see if he has a history of that. His BMI, he's class 1 obesity. He's not sick, no acute distress. Okay. What do we see on exam? Frontal bossing, widened nose. He has impaired peripheral vision, dental malocclusion, enlarged hands. Lungs and heart are good. Abdomen is good. Oh, great. This guy's got a lot of things. So we have a lot of things. Let's just organize it. What's our problem list for this guy? Obviously, the stuff he came in for, like low libido, right? How would you characterize his physical exam findings? Acromegaly, right? Those classic things. But is it common for acromegaly to also have the frontal or the peripheral vision loss? Could, right? If it's a macroadenoma, right? So it's pointing towards that. So again, he's tired. He has a high blood pressure. We can't ignore that. It's hard to dismiss that one because he's got all of these other things going on. All right, so we did a good physical. We got a good history. What do we do next? Labs. What labs? What's the first lab you could do if you're worried about acromegaly? IGF-1. It's high. Now what do? Yeah, we need to get a fasting, and we can't just test growth hormone, right? So we're going to do that growth hormone test where you give them sugar, the oral glucose tolerance test. But specifically, we're trying to suppress growth hormone, right? Because in a hyperglycemic state, growth hormone is supposed to be low. In this one, it's high. His random IGF and his repeat IGF that's fasting the second time is high. And oh crap, his prolactin is high. This guy's got all of the things. Okay, so we got a lot going on. Can we say we've confirmed the somatotrophic secretin adenoma, the acromegaly? Yeah, but now we have this prolactin elevation there, so we should probably make sure he doesn't check his thyroid, right? So here's our summary. High prolactin, high IGF-1, and then elevated growth hormone after our glucose suppression test. Now what do we do? We get those extra labs, so what should we do? An MRI, right? Let's get that MRI. And we have a 3 by 4 by 3 centimeter mass. And it impinges on the optic chiasm. And yeah, so space occupying effects, right? Erosion of the sella. So macro or micro?
Macro.
Yeah. Which goes along with this guy's symptoms. Are we surprised? No. So what's your diagnosis? You can diagnose it just from everything you have right now. What do we have? So, maybe Yes. And what else maybe?
And
Prolactinoma. Perfect. Good. So the somatotrophic adenoma is the acromegaly, and then the hyperprolactinemia. Is it the prolactinoma, or is it, is it both? Right. 15%. Somatotrophic adenomas can also cause excess prolactin. We already know it's a macro. How do we treat this? Surgery, right? Because definitely has this predominantly acromegaly symptoms. Yes, he has the prolactinoma. So guess what? We can do surgery, and we can give him what? Now I'm giving you the answer. Why can we give him a dopamine agonist? Right? The caprolactin is because of that, to treat that prolactin symptoms, right? So if he doesn't want surgery, we can do a somatostatin analog. But he wants surgery. He's done living life this way. And it's a macroadenoma. He's having vision changes, headaches, all these things. So we monitor, after he has surgery, we monitor him. And of course, does this all make sense? Right? Because with acromegaly, we have internal organ enlargement, right? So we have to rule out colon polyps. We have to rule out cardiomegaly. So we need to do an echo, an EKG, screen him for sleep apnea, screen him for diabetes, all of the PCMB stuff, okay? Don't forget about this, please. Oh, I need to update my slides because that was from last year when I taught when it was voting day. And Halloween. So enjoy your day off. Study hard for farm. And I think